Hello, everyone. Unfortunately, I will not be able to be live with you today, but at the end of the session, you will set all your questions to the chat box, and I will answer each and every one of them with an email. The Aohua team will inform me, and I will have all your questions answered. And I'm very, very disappointed that I will not be live with you tomorrow, because I really, really enjoy this monthly interaction that we have. So today we're going to talk about an amazing topic that comes to our practices. I still remember the first time that I diagnosed laryngeal paralysis in a Rottweiler, and I didn't know what this was. The sound could be heard from the reception of the clinic. So these cases are really difficult to manage, especially when we have respiratory distress, but they're very, very interesting in their diagnostic approach. And also a lot of people have a difficulty into distinguishing between laryngeal paralysis, paresis, and the collapse. And these are the terms that we will try to clarify today. I have to thank Aohua for giving me the chance of these amazing webinars as well. Okay, let's say that we have a dyspnoic patient. Let's see these differences in dyspnea. Let's check first this one, this dog. You can see how the abdominal walls, how the chest is going up and down. And I don't know if the sound is clear enough. But you can see the wheezes coming from the larynx. Let's see this one.
Clara, ciclo.
This is like snoring a bit, isn't it? Let's listen to this poor cat here. This noise in this cat is produced by the retrograde swallowing of nasal discharge. We have open mouth breathing in all of these cases. And you can see the discomfort that they experience. It's really difficult sometimes to actually locate if the sounds come from the nasopharynx, if the sounds come from the larynx, if the sounds come from the upper or the lower respiratory tract. So these are the 5 groups of diseases, of patients that can be admitted to a hospital with dyspnea. So the first group are diseases from the upper airway part, and it's the branchocephalic obstruction airway syndrome, laryngeal paralysis, tracheal collapse, or something neoplastic in these regions that actually obstructs the path of the airflow. The second group is the lower respiratory tract. So each group of these patients has produced different sounds as well. The second group is lower respiratory tract, pulmonary parenchymal disease most of the times, non-cardiogenic pulmonary edema. The third group is pleural space disease. So we can have severe dyspnea from pleural effusions, from pneumothorax, from pneumothorax, from neoplastic diseases. And group 4 are cardiac disease patients that can be admitted with respiratory distress in our clinics, acquired and congenital cardiac diseases. And also the last one is a very, very interesting one because we have a lot of obese animals now, or could be also stress-induced, a lot of obese animals with no underlying pathology that can be admitted, especially during summertime, during these very hot months, with dyspnea and clinical symptoms, detrimental respiratory clinical symptoms. Of course, obesity is a disease by itself. And according to where the location of the dyspnea is, we have inspiratory dyspnea, expiratory dyspnea, mixed sometimes throughout the breathing pattern. For in the upper airway obstruction, which we are going to be focused today, most of the time we have expiratory dyspnea, and we have a very, very audible, loud and audible noise. Stertor, stridor, we're going to see the differences about stertor and stridor. Because I had a quiz in social media today about two animals. Is it a stertor or a stridor? And people cannot distinguish sometimes between these two noises. In lower airway obstruction, for example, we have expiratory dyspnea, and we have a wheeze, which is audible with the stethoscope, and sometimes can be heard with our ears. And the rest, I will not go through the rest, but I just wanted to highlight the fact that in upper airway obstruction, and especially in laryngeal paralysis, we have inspiratory dyspnea. So when we're taking a clinical history in these patients, let's have a look. At this first one, let's play the game and name the sound. This is the sound that reverse sneezing is giving. Let's see the next one. This was a clear cut from tracheal collapse, but sometimes we can get confused because sometimes we have both entities, diseases going on. Let's hear about that one. That comes from the upper airways as well. And this was actually a kennel cough. So it was tracheobronchitis, tracheitis mostly in this dog. So what are we giving special gravity when we are taking a clinical history in these patients? So we are asking about, we're trying to make clear if the coughing or the gagging was first. For example, you saw that in this animal, the coughing was first, and then it was then preceded the gagging. And sometimes we might have also regurgitation of foamy or material or saliva. So we're asking about phonation changes in barking, duration and the severity. How long is it induced by, for example, a weather, a hot weather, a warm weather, a humid weather? Are these symptoms exacerbated during changes of the weather? Is there any cyanosis? Do the owners detect a blue tongue when the symptoms are apparent? Is there any exercise intolerance, unwillingness to move? What about the walking test? A lot of people and a lot of kennels, especially in the brachycephalic breeds, as I will show you, take the walking test, which I will explain later what it is. Vomiting is regurgitations. Are these episodes of loud voice from the upper airways are they followed by any vomiting, regurgitation, or dysphagia syndromes? So we have to actually tell the difference between reverse sneezing, as I told you, stertor, stridor, hacking, gagging, coughing, all of these things. I know it's difficult, but when you get familiar with where the sound is produced, then it's more easy to localize the lesions. So both stertor and stridor are they involve turbulence of the airflow in the respiratory tract. So they're produced in the upper respiratory tract. The stertor is characterized by snoring or gasping upon inspiration. So you remember the Maltese dog. And the location is the nasopharynx or the soft palate. And then the stridor is a high-pitched respiratory sound generated by the larynx during inspiration again. So the location in stertor is the nasopharynx and the palate, and the location in stertor is the larynx. In stridor, sorry, is the larynx. So you see the different locations where these two sounds are produced. And this is actually in the physical examination, what we do is, of course, we do a head exam. I will talk to you later about the walking test. So we do a head exam, nose, ears, in order to see is there any nasal discharge, any ocular discharge. Is this a systemic disease or is it just localized to the upper airways? The lymph nodes, of course, in order to detect if we have, for example, peripheral lymphadenopathy, this is a systemic disease. It's not just located to the upper airways location. We do a very, very thorough oral examination in order to detect any ulcers, any discharge, as I told you, airflow, dental diseases. We palpate the hard palate in order to see if it's intact throughout the surface. So to detect also if there is any elongation, if there's a deviation, the tonsils for eversion, are they everted or not? And of course, we palpate the neck for any masses. Definitely, we're going to do a thoracic auscultation and rectal temperature. So we complete the physical examination. And after we complete the physical examination, in some cases, we have to do a neuro exam because a lot of the diseases that originate, that actually trigger laryngeal disease stem from neurology and neurological problems, and we have to detect that. And our physical examinations has definitely involves the walking test. So this is a test that involves a walking distance of 12 minutes, and I will show you in the next case how to do the walking test. So we measure after the dog completes the test. Some of the dogs might never complete the test because they can't, especially the brachycephalic ones. We detect changes in the temperature if we have hyperthermia, if the dogs can complete the whole exam without stopping or without having respiratory distress. We have 3 degrees in the walking test: the failed ones, the ones that could not complete the full exam, and the ones that are rejected, that could not complete any of the walking test. So in order to go on, I know that anatomy is very boring, but in these cases, it's very, very important to define the anatomic features of the larynx. So as you see here, we have this is the dorsal pharyngeal wall, and this is where the esophagus is. This is the entrance for the esophagus, the cricoid arc here. So we have the corniculate process, which is very interesting here, and the cuneiform process. These are the arytenoids that are very, very important as well. And I have here, because sometimes people do not know where the nasopharynx is and where the oropharynx is. So I have it also in the next, in this photograph, in this radiograph, in order to see the location. So the larynx is responsible for the regulation of the airflow. It's the voice box, actually, controls the phonation, and also it protects the lower airway from aspiration during swallowings from aspiration pneumonia. Here is the epiglottis, and here is the tongue. Okay, and these are the vocal folds, sorry, these two. And this is the rima glottidis. This is the opening, okay, through which we go into the trachea. So these are the anatomic features that we always inspect when we do a laryngoscopy. The cuniculate process, the cuneiform process, the aryepiglottic fold, the vocal folds, as I told you, and this is the epiglottic. So the rima glottidis is the gap between these two vocal folds, okay? And there are intrinsic muscles of the larynx that are innervated by the caudal laryngeal nerve, which is actually the terminal segment of the recurrent laryngeal nerve. And whenever we have damages due to trauma, to neoplasia, to surgery, to the recurrent, to one or both recurrent laryngeal nerves, this is when we have laryngeal paralysis, unilateral or bilateral. Cricothyroid muscle is innervated by the cranial laryngeal nerve. And let's see now what happens when we are at rest, during inspiration, and when we're swallowing, because whenever you do a laryngoscopy, it's not enough just to inspect what's happening inside the larynx. You have to have your assistant telling you that now the dogs is inspirating, or now the dogs is expirating, so that you can compare the information that you're listening to with what you're seeing, what you're inspecting in your visualization, in your direct visualization. Okay, so at rest, the rima glottidis is very narrow. During inspiration, the rima glottidis is made larger. And when swallowing, the rima glottidis gets narrowing because we don't want aspiration pneumonia. So the epiglottis completely covers the rima glottidis, preventing the passage of the food, of the bolus of the food into the trachea. So tonight's goals is to actually say, this is the normal larynx, this is the laryngeal paralysis, and this is the laryngeal collapse. And some people actually confuse what's laryngeal paralysis with laryngeal collapse. As you see that in laryngeal collapse, there is no rima glottidis. The arytenoids are closed and the animal cannot breathe at all. This is an emergency case. Laryngeal collapse is not a case that can wait. It's a case that has to undergo emergency treatment of acute respiratory distress, like improve ventilation, reduce the laryngeal edema, oxygen supplementation, dexamethasone, a short-acting steroid, for example, and sedatives a lot of the times, okay? And sometimes cooling procedures as well, because these animals have hyperthermia. So anywhere in this pathway that we will experience disruption, this might be a cause of laryngeal collapse. So you can see that this is the normal larynx, inspiration, expiration, and this is the unilateral paralysis when one of the arytenoids is not abducted. And in bilateral paralysis, they both stay, they're not moving. The arytenoids are not moving. So anyway, in this path, medulla, vagus nerve, the recurrent laryngeal nerves, the caudal laryngeal nerves, or problems in laryngeal muscle innervation, they can cause laryngeal paralysis. Let's listen to this. You see that this dog has an open mouth, breathing. You can see the discomfort. So what are the signs of laryngeal paralysis? So we have an inspiratory stridor, as we said. So the strettor is not a sound of laryngeal paralysis. The stridor is the sound of laryngeal paralysis. The arytenoids are not actively rotated, and the rima glottitis remains narrow. So we have an upper airway obstruction. We have phonation changes. A lot of animals come because of exercise intolerance, of changes in voice or changes in barking, or they stop barking. We have gagging, retching, coughing, vomiting and regurgitation that come after the gagging and the coughing. Dysphagia, the regurgitation, is a symptom that accompanies a lot of time the cases of laryngeal paralysis, because there is a neurological component in all of these diseases, as I will explain later. Dysphagia, respiratory distress, cyanosis and syncopic episodes, especially when we have acute respiratory distress, and of course, hyperthermia. Retching and gagging and regurgitation we can have in a lot of cases. So when you sedate animals, always look for foreign bodies, for masses. We said that we should do a very thorough oral cavity examination. Look at this one. This was a video that some owners have sent me prior to doing an endoscopy, a laryngoscopy to this dog. Chew the food. This dog apprehended the first phase really well. It could chew, so the jaws could actually apprehend the food and chew the food. But in the first phase of swallowing, this dog actually encountered an immense difficulty. And we thought that this could be, you know, some kind of a neuromuscular disease or a tumor or mass or of some kind. And now it's retching and goes into regurgitating the content that it tried to swallow. It actually can swallow the content. So when we sedated the animal to put it under laryngoscopy, we saw that there was a thread underneath the tongue, which is very, very common in cats, not common, very uncommon in dogs. But once we took the whole thread out, the symptoms stopped. So please do a very thorough examination before referring your cases, because it might be something very simple as that. Okay. So there is the congenital laryngeal paralysis, and especially in huskies and Malamute, especially Siberian huskies. So the phenotype of these dogs with congenital laryngeal paralysis are blue eyes, white markings, as you see here, the white markings, blue eyes. And some of them have mucosal tags. Most of them have oral mucosal tags or tissue bands. These are the tags and the tissue bands. So it's very, very, when you encounter, when a Siberian Husky puppy comes to your practice and has tags, bands, and some white, you know, elements in the face, please beware. If this animal develops a very strange sound over the next months, always keep in mind that it could be congenital laryngeal paralysis. It's a mononeuropathy of the recurrent laryngeal nerve. We do the lateralization, the cricoarytenoid lateralization. The prognosis is very good. So just keep in mind this congenital form. Other breeds that could have congenital laryngeal paralysis are the Bouvier de Flandre, the Bull Terrier, the Pyrenean, with different kinds of heritages. In the Bouvier breed, it is an autosomal dominant inheritance. So the Pyrenean mountain dogs as well, the Huskies, as we said, the Dalmatians, the Rottweilers, and the German Shepherds, the white, the Canadian, as we say them, Shepherds. Their laryngeal paralysis is a part of polyneuropathy disease that affects other organs as well, like the esophagus. And of course, we have the laryngeal paralysis with the breed here overrepresented, the Labradors and the Golden Retrievers. The median age is around 9 years old. So in the congenital forms, we have young animals having the stridor or the exercise intolerance. And in the acquired laryngeal paralysis, we have older animals. So any disease of the recurrent laryngeal nerve, like neoplasia, trauma, For example, sometimes we have foreign bodies penetrating the esophagus, and this causes also laryngeal damage or damage from the endotracheal intubation, infection, complications from any surgery in this area, in the thoracic or cervical area. Even though hypothyroidism has not been linked directly, evidence-based, with laryngeal paralysis, there is a big percentage of dogs exhibiting laryngeal paralysis that have hypothyroidism. So it's different to say that hypothyroidism causes laryngeal paralysis, and it's different to say that hypothyroidism is linked to laryngeal paralysis, to dogs that exhibit laryngeal paralysis. And of course, diabetes, myasthenia gravis, because these diseases caused peripheral polyneuropathies, immune-mediated polyneuropathies, and when we don't find any other underlying disease, then we call it idiopathic laryngeal paralysis. And of course, I want you to know about the gulp. This is a syndrome that has been emerging during the last years, and we diagnose more and more of these cases. So this is the geriatric onset laryngeal paralysis polyneuropathy. It's in old dogs. The onset is from 8 years old up to 13 years old, and more, of course. And we see a lot of these animals, and we will see what the clinical symptoms are. So it's non-inflammatory, it's degenerative disease. And in these animals, it's not only the larynx that has a problem. We have a generalized neuromuscular weakness. They cannot walk very well. They have exercise intolerance. They have megaesophagus or problems in esophageal motility. So 11% of the cases may require an esophagogram in order to diagnose the esophageal dysfunction. And also, if you do, in these cases, a tie-back surgery, this is the surgical technique that we use in a lot of cases of laryngeal paralysis, they could go on exhibiting weakness, exercise intolerance, even after the tie-back surgery, because this affects not only the larynx, but it has a more systemic appearance. So we have clinical neurological deficits and electrodiagnostic abnormalities in each case, and a poor prognosis to return to normal activity, because these animals will fade over the years. So there was a very nice paper in order to estimate the esophageal dysfunction in dogs with idiopathic laryngeal paralysis, because we had a lot of dogs with the median age of 10, 11 years old that used to do regurgitations and had this noise in their larynx. So the objectives of this paper were to compare esophageal function in dogs with idiopathic laryngeal paralysis, where no underlying disease was found, to age and breed matched controls to determine if this dysfunction could be associated with aspiration pneumonia over 1 year, and to compare the neurological examination of dogs with idiopathic laryngeal paralysis at presentation and at 1 year. So the conclusions were that dogs with idiopathic laryngeal paralysis also have esophageal dysfunction. So laryngeal paralysis and esophageal dysfunction should actually give us a clue about the gulp syndrome if we have a geriatric patient, should alert us to think about the gulp syndrome. Post-operative aspiration pneumonia is more likely in dogs with higher esophagography scores, and that's only normal. If the more the esophageal dysfunction is, the more the risk of aspiration pneumonia is. And dogs with idiopathic laryngeal paralysis most likely develop generalized neuropathy over the course of 1 year. So we had a patient, and I will show you the next case, that was actually went to the op room and did amazingly fine and can breathe now. But this dog has a lot of other neurological deficits. And over the next year, the owners should be aware and should be notified that these cases will not go well, not because of the larynx. Of course, this dog will never die out of acute respiratory distress right now because we had the tie-back surgery, but the neurological status and condition might never get better. So how do we diagnose laryngeal paralysis? So we can do the videoscopic laryngoscopy, videoscopic observation, visualization, or direct transroller observation of the larynx under light general anesthesia. There's a lot of conflict here. Should we do the laryngoscopy when we induce anesthesia? Should we do the laryngoscopy while the animal is waking up? So I'm used into assessing the laryngeal function once inducing very, very light anesthesia. But I know that there are a lot of colleagues that want to actually assess the laryngeal motility and function once the animal is waking, the patients are waking up. Watch out for the paradoxical movements of the arytenoids because they might give false negative results. So the arytenoid cartilages move inward during inspiration because of the negative intraglottic pressure. So that is created by breathing against the obstruction. The cartilages then returned to their normal position during expiration, giving a false impression of abduction. So this is what we call paradoxical movements of the arytenoids. So in inhalation, we have narrowing of the rima glottidids, and in exhalation, we have opening of the rima glottidids due to air pressure. And this gives the impression of normal or of some kind of movement, which is not, it's a false negative result. We can use electromyography in dogs as young as 12 weeks. I'm not familiar with these techniques. I guess neurologists are more familiar with this, with electromyography, echolaryngography, but it hasn't been proven that neither echolaryngography or transnasal laryngoscopy actually have a better result in diagnosing laryngeal paralysis than endoscopic laryngoscopy. Before going into endoscopy, as I always say, in every system, respiratory, gastrointestinal, urinary tract, what we do as a first step is always do a pre-op examination and check hematology, biochemistry. Here, when we have a suspicion of laryngeal paralysis, we definitely have to check the thyroid function, not with a simple T4, total T4. We also check the free T4 by equilibrium dialysis, the canine TSH, and the antibodies against against T4. Also, the acetylcholine receptor antibody titers for myasthenia gravis, because this could be a part of myasthenia gravis. Masticatory myositis with the anti-2 antibodies, thoracic radiographs, definitely to rule out aspiration pneumonia, megaesophagus, or any other tumors, neoplastic processes. And the goals of the laryngeal exam, first, we check the structures. What are the structures? Are anatomical features? Are they normal morphologically, anatomically? The cartilages, the vocal folds, as we said, the laryngeal saccules, are they inverted or not? The epiglottis and the aryepiglottic fold. So first we check the structures. Then we go to the mucosa and we see how the mucosa is. Is it pink? Is it cyanotic? Are the superficial vessels of the tongue cyanotic? I mean, then we check in the larynx if the superficial vessels are visible or not. And they should be visible. Are there any secretions or edema? Any proliferation, like webbing, for example, in very young animals, or granuloma tissues? Evaluation, and then we go to the evaluation of the arytenoid movement. So we first check the structures, the mucosa, if there are secretions or not. What kind of secretions are they? Are they secretions, saliva secretions? Are they maybe blood secretions? So we have to evaluate all of those things. And a lot of people ask me, what is the ideal anesthetic protocol? So the ideal anesthetic protocol is to keep and to maintain the laryngeal reflexes while achieving an anesthetic depth sufficient to allow jaw relaxation. So we have to relax the jaws, and also we always keep the mouth open so that the animal does not actually grasp our endoscope, but it has to be a very light plain anesthesia. And sometimes the challenge is that even in light anesthesia, we might have apnea or swallow very short inspirations, and this makes it very, very hard for us to diagnose these diseases. So what is the equipment that we might use? The equipment is a laryngoscope. Please always use the laryngoscope and use a long blade, mouth gags. Sometimes I put 2 mouth gags in these animals because I'm really scared that they might chew on my scope. ET tube, definitely. You can do laryngoscopy with either a rigid scope or a flexible scope. I mostly use this flexible scope here of Aohua because I find it, because most of the times when I check the larynx, I dip in the anesthesia and then I go to the trachea, so I want to be ready, and I don't use the rigid scope. I use the flexible scope. I first do the laryngoscopy, and then I do retrograde rhinoscopy in order to see the nasal choana, and then I might also go to the trachea. So for this purpose, in order to make my life easier, I use the flexible scope, but you can do as you like. Of course, video, detailed report, and anesthesia monitoring. We definitely need, this is a procedure that you definitely need an anesthesiologist. So what do I do as sedation? As pre-med, a lot of people use butorphanol and ACP. Most of the times, and there's the induction with alfaxalone or propofol. And if you want to enhance the respiratory, if you want to use something as a respiratory stimulant, you use doxapron. So most of the times I do none of those, maybe a bit of butorphanol, and then go straight away with propofol in order to check the depth of anesthesia up to the effect that I want. So what about doxapram? When do we use doxapram? Doxapram acts within 30 seconds of administration, and it will enhance the, it's a central nervous stimulant, so it increases the respiratory rate and it makes the laryngeal paralysis, it makes easier. If you have any doubts if an animal has laryngeal paralysis or not, it makes easier for us to diagnose it. Okay, so it will never make an abnormal larynx function in a normal manner. So probably if the larynx appears abnormal before doxapram, and if you inject doxapram, it acts normally, then this dog has not laryngeal paralysis. And this was a false positive reaction that you had before. So if you go into scoping and you see that the larynx, that the arytenoid cartilages are not moving well, they're moving in an abnormal way, and you inject doxapram, and then the larynx looks normal, then it is normal. Forget it. There is no laryngeal paralysis. Okay, so this helps you actually a lot in your diagnosis. It will override the potentially depressant effects also of anesthesia, and this is why it gives us a very, very clear picture. So if you have any doubts, use doxapram. So what do I follow? Pre-oxygenate always. Pre-medication, ACP or butorphanol. Most of the times I do butorphanol. They're very, very low dosages. Induction with propofol. And as a respiratory stimulant, doxapram, as we said. This is normal. So in a normal larynx, we have symmetrical arytenoid abduction. Okay. Thin and tough abducted vocal cords. These are the vocal cords here. And I want you to keep this picture in mind because I will show you later. These are very thick and straightened vocal folds, as you see. And you can see here how the abnormals are. They're very flaccid. Their movement is not coordinated. And you can see here that the submucosal capillaries are visible. Here we have edema. We have asymmetrical arytenoid abduction. Excuse me. Let's go here. Mucosal hyperemia. So we have laryngeal edema. And of course, we have secretions here in the larynx because they cannot be swallowed properly. The function is not proper. So they tend to accumulate. And this is why these dogs are gagging all the time. So let's see this dog, 12 years old. This is upon admission. You see the cyanotic tongue. This dog is in real trouble, cannot breathe properly, in respiratory distress. You see the open mouth. You see here and you can hear the stridor. So we have severe dyspnea. Let's see that one as well. That's at home. This dog is making severe sounds. And right after drinking water, we have regurgitation of foamy material and saliva. If you hear this noise at the reception of your clinic, this is laryngeal paralysis. It cannot be anything else. Okay, so this dog had severe dyspnea, especially if excited or in exercising, while exercising. This dog is not exercising at all. It cannot afford not even to go out from the car into the reception of the clinic. Labored breathing, labial respiration with the mouth kept open. And as you saw, the corners of the lips were retracted, always like smiling, but it's because of the effort of the labored breathing. We have laryngeal stridor, like roaring, like a lion, coughing, gagging, regurgitation, hypersalivation, although we had good appetite. The appetite was not reduced at all. Always throat clearing and hacking. And also, this dog exhibited hinted weakness, generalized weakness, and an unsteady gait. Of course, it had other orthopedic also problems like osteoarthritis in hips, in elbows, in the knees. So we had other, you can hear the sound. Okay. What are the physical examination findings? Palpation of the abdomen. Let's see him in the clinic. You can see the posture. This dog does not want to walk. This unwillingness to move. Palpation of the abdomen was normal. The body condition score 6 out of 9. The neurological examination, we have hypoflexia in all 4 limbs, but of course we have other orthopedic as well as neurologic diseases, decreased postural reactions, hypotonia and appendicular muscle atrophy. Pain perception was normal. Palpation along the spine, no pain detected at all. The respiratory rate increased. The heart rate was normal. Buccal membrane cyanotic, and the temperature was 40.2. Because it had hyperthermia due to the excessive effort. So we did a neuro exam. In these patients, always you have to do a neuro exam to check on the mentation because you might have a generalized disease. So the posture and the gait, cranial nerves, placing responses, reflex and tone, sensation, everything. And this is the walking test that we did. Turigas. This is the dog's name. Okay, so we took him out of the clinic, and you see that this dog does not want to walk. Walk for 15 minutes or 12 minutes is impossible for this dog. He's just dragging himself. So the result of the walk test is either approved, failed, or discontinued. The dog walks for 100 meters in 12 minutes or less and recovers sufficiently. The dog then fails to recover for this 12 minutes walk, or never is not able to successfully complete. And the discontinued is because the test temperature is very, very high. We actually never completed with Rigas. He just went for 200 meters, 300 meters the most, and that was the best that he could do. He just stayed there, and he also regurgitates, if you see now. So you see that saliva, he regurgitates saliva during walk. This is like, you know, a torture for this dog. Step by step, he's going step by step and is unwilling to proceed with a test, with a walking test. So this is when he returned back in the clinic. So whenever we have a case, we always create a problem list. Here we have dyspnea and labored breathing. We have gagging and regurgitation. We have paresis and exercise intolerance and voice changes. And of course, the stridor. And you can see here how severe the dyspnea is. And you can see the muscle atrophy also in his hind limbs. You can see the muscle atrophy here. Okay, let's go to the hematology. The hematology was pretty much normal. Normal white blood cells, a bit hemo concentration, which is absolutely normal due to the excessive panting that the animal had. And besides the mild increase in ALT, which could be due to hypoxia, but of course, we would anyway investigate with an abdominal ultrasound, a CT scan, in order to see if there's any other concurrent disease in the liver or any other systemic disease that might cause elevated ALT, which is not that much elevated, to be honest. It's a mild elevation. It's not even double-fold up, two-folds up. So everything else was pretty much normal. We did cholesterol levels, CK, which were normal. The thyroid function was normal. And it would surprise me if an animal at 12 years old would develop, you know, hypothyroidism that much late in his seniority years. Pre and post bile acids tests were normal in order to check the liver activity. Baseline cortisol normal. We wanted to check also for Addison's disease. And the acetylcholine receptor for myasthenia gravis was normal as well. This was actually a plain lateral radiograph focused on the spinal cord of Rigas because they saw, the orthopedics saw his limbs movement, and they wanted to check the spinal cord. So I don't have a radiograph of the thorax. He should have been checked in the thorax for aspiration pneumonia. Okay. So the sedation protocol, as I told you a bit earlier, light plane anesthesia, because we have to do a laryngoscopy now. Light plane anesthesia. So propofol, induction with propofol, given slowly up to effect. And the food withdrawn 6 to 12 hours before the examination. And let's have a look at his laryngoscopy. This is a very recent case. I saw this case on May 24 now. So you can see the epiglottis. You can see the palate. no movement, and a lot of excessive saliva, excessive secretions. This dog has a bilateral laryngeal paralysis. The arytenoid cartilages are immobile and they're moderately inflamed. And I just left the secretions here so that you can see that they're accumulating over the course of the examination. So we have erythematous vocal folds due to the turbulent airflow. The vocal folds are hidden here. And in normal arytenoid cartilages should abduct during inspiration and adduct to the paramedian position during expiration. And you always have to hear your assistant, as I told you, that he's telling you, now the dog is inspirating, now the dog is expirating. Okay. We sent off Rigas for a CT scan. And in order to detect, because of the age, we wanted to exclude any masses, neoplastic processes in the neck region. And we found bilateral tendinopathy of the biceps muscle, pectus excavatum, splenic nodules, right knee osteoarthritis and hip osteoarthritis, and other irrelevant to the neck findings. So we excluded any neoplastic disease. Now, the treatment of laryngeal paralysis is the tie-back technique. One or two simple interrupted sutures are placed between the dorsolateral here and here, the dorsolateral aspect of the cricoid cartilages and the muscular process of the arytenoid cartilage. And this is what we did to Rigas. Actually, the unilateral left arytenoid lateralization, which is the gold standard, the tie-back technique. What are the complications of the tie-back technique? The complications might be aspiration pneumonia. And we have warned the owners that he should be fed very, very cautiously from a height. So, and maybe in a slow down eating bowl so that he chews everything that he's eating. Seroma, persistent cough or gagging, but none of them. And I thank my colleague, Dr. Durdas, for the operation and the photographs. And this is after the tie-back technique. You can see that this arytenoid is tied back. So note the permanently abducted left arytenoid cartilage, as well as the absence of any blood or swelling. This is a very, very easy technique. So further enlargement, it has been, some people ask, why do we only do unilateral tie-back and not, in both sides? Because further enlargement of the rheumatoid offers minimal advantage in reducing airway resistance. So why to increase the risk of aspiration pneumonia? So it is performed on the left side, because this is another question. Why do they do the tie-back on the left side? Because most of the surgeons are right-handed. So the left side is generally easier to operate on. There's no other, there is no other reason for that. And that's Rigas 1 day postoperatively, and you can see that we have no open mouth breathing anymore from the first day. And this is 4 weeks postoperatively. He's barking again, and he doesn't have this noise, the stridor. And he doesn't have respiratory. Of course, he has some gagging because he has some saliva. Here, he's very playful again. He's very responsive to his owner. He's playing like a puppy again. And this is his walking. And I have to remind you and to highlight that this is a very, very hot period in Greece. We have a really hot summer with like 38, 39 degrees, and he's able to walk, and he's taking the walk with all the other dogs of the family without being interrupted at all. So another case is that of Millie, a Labrador, 7 years old female spayed. with a primary complaint of exercise intolerance and labored breathing. So this is a 7-year-old female dog. No history of trauma, of foreign bodies, prior surgery. So this dog was gagging and retching and coughing, regurgitating. It had an inspiratory stridor, dysphagia as well. She was not able to swallow properly. And the owners, what they perceived is that she was leaving food. So the food was going out of her mouth in the bowl. So always ask the owners if they're detecting food in their bowls, in their water bowls. We had change in phonation, ptylism, and also generalized weakness with proprioceptive deficits. And for the past 5 months, the colleagues have given her, she was administered doxycycline and rofloxacin, maropitant, aminophylline, because some of the referring vets thought that it could be lower airways disease, pneumonia, or bronchial disease, prednisolone and ranitidine, but no clinical improvement. On the contrary, we had progressive deterioration. So you see that she's in her house at rest, and she has excessive panting. The stridor is induced only after strenuous exercise, only after exercising or after getting, enthusiastic. It's not constant as it was in the previous case. You can hear it even now, but the panting, the noise from the panting exceeds the stridor. And she has this lip licking. So let's go to the physical examination. Heart rate was pretty much normal, strong pulse. Mucous membranes were not cyanotic. In this case, they were hyperemic. And the capillary refill time, 1 second. The respiratory rate increased, the rectal temperature increased, we had mild dehydration, and in the thoracic auscultation, we had abnormal lung sounds like high-pitched wheezes, and this always raises the suspicion of aspiration pneumonia. The neutrophil, the CBC revealed a neutrophilic leukocytosis, so now we're more seriously thinking about aspiration pneumonia with a regenerative left shift, elevated HCD due to dehydration, markedly increased alkaline phosphatase and hypercholesterolemia. The CK was four-folds up. The CRP increased. She was tested for all the infectious diseases that are prevailing here in Greece, like leishmaniasis, Ehrlichia, Borrelia. And we always do a Bartonella-Hensley. The toxoplasmosis was performed because she had a very high CK. So we wanted to know if this was a neuromuscular disease generated by toxoplasmosis, maybe. And these are the thoracic radiographs. And of course, we have a mild interstitial and alveolar pattern in the left caudal lobe, which is like aspiration pneumonia. Most of the times, the affected lobe in aspiration pneumonia is the right middle lung lobe, but here we had the left caudal lobe with a lot of, you can see here, lesions. So we prescribed antibiotic stimuli, 10 days of amoxicillin clavulanic acid in order to get rid of the pneumonia. And as you see, the pneumonia is over. And we took the risk to do a barium contrast study, an esophagogram, in order to check the function of the esophagus. And as you can see, we had esophageal hypomotility. Normally, when you give the esophagogram, the barium, it should be in the stomach and not at all left in the esophagus. But here you can see that throughout the esophagus, there is a lot of barium left. So we have functional megaesophagus. So we have an animal that has a stridor, a periodic stridor, and also gagging, regurgitating, and an esophageal hypomotility. So we did This is not me, I can assure you. This is a video from the owner. Okay, and you can see that this dog is practically dying. I mean, it cannot move. They have a Pampers for the urinary, because the urine is going out. It has urinary incontinence, but it's not true incontinence because it's just that the animal does not move. She is unwilling to move. Okay. We did a thyroid profile, normal anti-2M muscle fiber antibodies normal, but the acetylcholine receptor antibodies were positive from myasthenia gravis. So we tried, apart from the general approach, to also check for specific diseases, because this is a 7-year-old Labrador. And let's check. As you can see here, we have edema, a lot of edema, excessive secretions, and the larynx is not moving properly. It's not abducting and adducting properly. And we have so many secretions. Again, sometimes I'm waiting for the animal to wake up a bit and I go in again. You see that you have a paradoxical, something like a movement here in the arytenoids, but the vocal fold, these are the vocal folds here. No movement. And then you go into the trachea. So we had laryngeal paralysis on grounds of myasthenia gravis. And what do? We gave pyridoxine, lansoprazole, and circlopate for the, oh, excuse me. I have to. This is probably from the clinic. I'm sorry, these happen. So sulcrafate and low-fat diet. And we did a cricoarytenoid lateralization with in these cases, there is an improvement, but actually we never did an operation to this dog. We just gave the the medication, and it improved. Let's go and see Pico. And I had it as a quiz as well. This is a Rhodesian Ridgeback. What is Pico doing here? This is reverse sneezing, but at the end of the video, you will see that there is a stridor from the larynx as well. So this dog is doing a reverse sneezing right now, but at the end of the video, it has a laryngeal stridor as well. And of course, difficulty in breathing. I'm going to show you later other videos of Pico. And he takes an orthopnoic stand posture as well. So the primary complaint, again, was exercise intolerance, labored breathing, gagging, retching, coughing, sometimes regurgitation of saliva, changes in phonation, episodic collapse. He was collapsing at times, orthopnea, and the neuroexam, his neuroexam was always normal. Look at him. He's out in the garden, and he's just standing like that without doing anything. He's not moving. He's opening his mouth. He's trying to breathe. He's trying to have a proper inhalation. And here, just because it's summertime, they have put ice on his neck because they thought that it could be, you know, it could alleviate his problem. So he's trying to breathe, the poor animal. You can see the degree of dyspnea that he has and the discomfort that he has. So he had a neutrophilic leukocytosis, a mild anemia with regenerative left shift as well. I see the anemia here I haven't actually written it here, but I see the anemia here. But it's of chronic disease. Monocytosis, oh, I've written it, mild non-regenerative anemia. A marked increase in alkaline phosphatase, hypercholesterolemia, CRP increased. Again, we checked for all the infectious diseases here. The CK was normal, the thyroid profile was normal, and the acetylcholine antibodies negative in this case. We also had a CT scan in order to exclude neoplastic processes. We had multiple hepatic nodules. We did not do an FNA in these nodules, and we should actually. Splenic nodule and focal atelectasis in the right caudal lung lobe on grounds of a chronic inflammatory process. So we did have an atelectasic right caudal lobe, probably due to aspiration pneumonia as well. So the laryngoscopy. You can see how flaccid the cords are. We cannot see the vessels. This is not a correct movement. You can understand that this is not a normal movement. This is the epiglottis here. Okay. Do you remember the photograph that I have shown you with the vocal cords that were tied straight? And here they're very, very thickened and with abnormal movement and very flaccid. So with us not having seen, and here it is shown very, very well, that the movement is very, very uncoordinated. This is not a good abduction and adduction. This was idiopathic laryngeal paralysis. We have not found any underlying disease. And no megaesophagus also in this. So this could not be considered a gulp. No other neurological, the neuro exam was normal other than that. It's very impressive. It's very impressive. A 4-case cotton, a German Shepherd cross, and remember that German Shepherds, 6 years old, and German Shepherds do have a tendency, especially in the congenital form. The primary complaint, again, exercise intolerance and labored breathing. She had gagging and retching and inspiratory stridor, change in phonation, and also some other recurrent pyoderma and otitis externa, and difficulty with warm weather in coping with her walks during warm weather. So this is upon admission. You can see the wheezes during inspiration and the effort that she's taking. Okay, increased the investigation. This is her radiograph. We have some, findings in the thorax, but they're not that prominent. Some donuts here and here, but they're not. It's not something outrageous. increased alkaline phosphatase and cholesterol, mild non-regenerative anemia, T4 and free T4 were low, canine TSH increased, and everything else was pretty much unremarkable. So we connected it with hypothyroidism. Let's see her laryngoscopy. So you will see no movement at all during inspiration and expiration. You see very, very mild movement. Of course, the vessels are shown here.
Ira.
And this is laryngeal paralysis as well.
Φύγε το κορίτσι μου, έφαγες,
She did the tie back as well.
Για πάμε, Φιλίππη. Σήμερα είναι μια βροχερή μέρα.
And she's back to her normal.
7 Μαΐου.
She's on T4 as well.
Φάγαμε.
And she's back to her normal
Κάνουμε
walks.
τον περίπατό μας.
She's a young adult dog. And she's actually
μόνιμος κάτοικος.
looking pretty good. And that's 2 weeks post-op. And the last case, because I always wanted to show you a case about laryngeal collapse as well. So this is Bizou, a Pomeranian cross, 9 years old, female neutered. And the primary complaint was cyanosis, respiratory distress, and syncope. Listen to her, listen to this sound. This is how she was admitted to the clinic at the examination room. Did you hear that? This dog was in real distress. So we did a tracheostomy. No diagnostic to these patients. You do not handle these patients to take blood samples, to do x-rays. You just keep them in a cool environment, provide oxygen. And if it doesn't work, sedation. If it doesn't work, do a tracheostomy, a temporary tracheostomy. And this is what we did actually to her. Anti-inflammatory dosages of dexamethasone, and laryngeal surgery if indicated at the same time. Let's see at her collapse. You see that there is no rheumaglottitis here. They're not abducted at all, the arytenoids. So the degrees of laryngeal collapse, grade 1, these are the laryngeal saccules, grade 2 and grade 3, which is a lot of severe. No airway passage here at all. And a lot of secretions. This poor animal could not breathe at all. At grade 1, we have eversion of the laryngeal saccules. Grade 2, we have medial displacement or paradoxical movement of the cuneiform processes of the arytenoid cartilages. This is the process, the cuneiform process, this part. In grade 3, we have medial displacement or paradoxical motion of the corniculate processes of the arytenoid. The corniculate is the A. So here we have grade 2 in this animal, in Bizou, because we had paradoxical motion of the cuneiform processes of the arytenoid cartilages. Okay. And of course, in grade 3, we have loss of the dorsal arc of the rheumaglottitis, as you see, everything is distorted anatomically. I will not talk about the branchicephalic obstructive airway syndrome. This is a totally different syndrome and a whole new lecture about it. The primary components are stenotic rares, macroglossia. These animals have a huge tongue, aberrant nasal and nasopharynx turbinates, elongated soft palate, and hypoplastic trachea. You always forget about the trachea in this syndrome. And the secondary components are the mucosal edema, everted tonsils, most of the times, everted laryngeal saccules, laryngeal collapse. So laryngeal collapse in these animals is a secondary component of their syndrome, of the branchicephalic obstructive airway syndrome. And of course, a lot of these animals have regurgitations. A lot of these animals are admitted to me as a gastroenterologist because they're regurgitating or they're vomiting. And it all has to do with correcting the upper airway disease, fixing the nostrils, the narrowed nostrils, cutting the elongated soft palate, and then the GI signs stop. So whenever a branchicephalic breed comes for regurgitation or for, vomiting, it might not be vomiting, but the owners say that it's vomiting. First, correct the upper airways, and maybe the GI signs will be corrected as well. Unless it is mucosal hyperplasia, which is not corrected with this. So what are the everted saccules? These are the saccules. These are the vocal cords. Okay. And this is what they look like. And some people operate on the saccules, but most of the times, if you correct the elongated soft palate and the nostrils, and you leave the saccules, they come back to normal. We don't operate on them anymore. And that's pretty much everything. This is a very, very interesting issue and topic for me. I hope it was interesting for you as well with the presentation of cases. If you have any questions, I will be more than happy to answer to each and every one of you. And I know that all attendees will receive, anyway, a link to the recording, to this recording. So I thank you all for the attendance and see you next month with another topic. And I have to thank Aohua as well for this opportunity to be in connection with you. Thank you. Have a nice evening, everyone.